All right, let's dive into embryology and see how it helps us understand these congenital and acquired conditions in the male and female reproductive systems. We'll break down the key developmental steps and why they matter clinically, especially for anyone prepping for those tough board exams.
Sounds good. We got to start with the basics, right? Three primary germ layers, the mesoderm, endoderm, and ectoderm. The mesoderm, that's where a lot of the action is. Kidneys, gonads, and those all-important Wolffian and Mullerian ducts. Those are the precursors to the internal reproductive systems.
Right, and the endoderm, what does that one form?
Endoderm, that's what gives us the cloaca and its membrane, crucial for the urogenital tract development.
Okay, and the ectoderm.
Ectoderm is the one that forms the external genitalia.
Got it. So by week 6, we start to see those gonads forming, looking like little genital ridges.
Exactly. And what's interesting is the testes actually start differentiating a bit earlier than the ovaries, maybe about a week ahead. So even at that super early stage, we see this little difference in the timeline.
Hmm, interesting. And this is when the fetus still has both the mesonephric and paramesonephric ducts. Can you break those down for us? What are they and where do they go?
Think of it like two parallel duct systems, each with the potential to go male or female. Mesonephric ducts, we also call them Wolffian ducts, they could become the male internal parts. The paramesonephric ducts or Mullerian ducts, those could be the female internal organs.
And which path they take depends on.
Hormones. It all comes down to the hormonal environment.
So let's start with the paramesonephric ducts. What makes them develop into female structures?
Okay, so here the key is Mullerian inhibiting substance, or MIS. The Sertoli cells in the developing tests, they produce it. If it's a male fetus, MIS causes those paramesonephric ducts to regress, basically disappear. But in a female, or if there's no MIS for whatever reason, those ducts develop into the fallopian tubes, uterus, upper part of the vagina. Like the absence of that inhibitor lets the female structures form.
So it's not a specific signal to go female, but rather the lack of the signal to go male. And what about the mesonephric ducts? What makes them go male?
That's where testosterone comes in. The latex cells in the testes, they produce this testosterone-like substance that tells the mesonephric ducts to differentiate into the epididymis, the vas deferens, and the seminal vesicles, all the essential stuff for sperm transport and storage.
So male development needs that hormonal push. Now let's talk about the vagina. How does that form?
That's a cool process. It's called vaginal plate apoptosis. So you've got this solid cord of cells, and then programmed cell death happens within this plate. This basically creates the hollow space that becomes the vaginal canal. Starts around week 22 and finishes up around the 5th month of pregnancy.
It's just amazing how all these complex processes are coordinated. Our material also emphasizes how closely linked the genital and urinary systems are developmentally. Clinically, why is that connection so important?
Because they develop so close together, right? And they even share some early structures. So if there's a problem in one, there's a good chance there might be an issue in the other. Like if a baby has a congenital issue with their reproductive tract,
Yeah,
you got to check out the urinary system too.
yeah,
Makes sense, right? Got to be thorough.
definitely makes sense. All right, let's move on to congenital vaginal defects. We should talk about vaginal agenesis, also known as Mayer-Rokitansky-Kuster-Hauser syndrome. What causes it?
It's basically the congenital absence of the vagina. Happens because something goes wrong with the paramesonephric ducts. Either they don't develop right in the first place, or they don't fuse properly with the urogenital sinus.
And the urogenital sinus, just remind everyone,
Oh
is...
yeah, sorry. That's the precursor to parts of the lower urinary tract and the external genitalia. So it's all connected, as we said.
And because of that connection, are there usually other abnormalities that go along with vaginal agenesis?
Yeah, a good number of these patients will have urinary system abnormalities too. Things like kidneys in the wrong spot, duplicated ureters, sometimes even a missing kidney.
So what kind of clinical findings would point to vaginal agenesis?
Typically, you have a genetic female, so XX chromosomes, but she doesn't have a vagina. She might have a uterus, she might not. It might be functional, it might not. And then you might see other issues with the skeletal system, especially the spine, or problems with the urinary or digestive systems. So it can be pretty complex.
So how do you diagnose it?
Well, you start with a physical exam, pelvic or rectal, to see if there's a vagina. Then you got to check the urinary system with something like an IVP. And of course, you do a karyotype to confirm the genetic sex. And then you might need spinal x-rays to look for any problems with the vertebrae.
And what about treatment? What are the options for creating a functional vagina?
There are some non-surgical options, like gradual dilation with dilators, but that takes a really motivated patient. Surgically, there are a few different ways to go about it. You can use a vulvoperennial fasciocutaneous flap, what some people call the Malaga flap, or you can do the Vecchietti procedure, which uses a device to gradually create the vaginal canal. There's also the Mackendorf procedure, where you use a skin graft to create the vagina, and sometimes we even use a piece of the colon.
I imagine each of those surgical options has its own pros and cons.
Yeah, for sure. Like the Mackendorf procedure, patients usually have to use a stent for a while to keep the vagina open, and there's always a risk of narrowing or fistulas. And if you use bowel, well, sometimes you get mucus production or bleeding during intercourse.
Tricky. All right, let's shift gears a bit and talk about acquired vaginal and vulvar defects. What are the most common causes there?
Usually it's cancer, like after surgery for colorectal or bladder cancer, or it can be from trauma to the area.
Is there a way to classify those acquired defects?
Yeah, there's a classification system based on the location and size of the defect in the vagina. It helps surgeons figure out the best way to reconstruct it.
And what are some of the options for reconstructing acquired vaginal defects?
Lots of different flaps can be used. Modified fasciocutaneous flaps from the groin, vertical rectus abdominis muscle flaps from the abdomen, bilateral gracilis muscle flaps from the inner thighs, and if it's really complex, sometimes we even use a segment of colon.
Wow. Okay, what about the vulva? What causes acquired defects there?
Similar to the vagina, it's usually cancer, infections, or trauma.
And how do you reconstruct vulvar defects?
If it's a small defect, a skin graft might be enough.
Yeah.
But for bigger or more complex defects, you might need a fasciocutaneous flap from the medial thigh, a gracilis myocutaneous flap, or maybe a pedicled ALT flap. That one can provide a lot of good tissue.
It's incredible to think how it all starts with those early steps in embryology. And then those early steps can lead to these congenital conditions, and then later in life, you can get acquired problems that require these really complex reconstructions. It really shows how interconnected everything is.
Yeah, embryology is like the foundation. It helps you understand where these congenital anomalies come from.
Hmm.
And even with acquired conditions, the principles of reconstruction, like how we use flaps and how we think about tissue vascularity, they all tie back to those early developmental pathways. It's a pretty amazing journey from those germ layers to a fully formed reproductive system. And when something goes wrong, it can be a real challenge to fix it.